Hello, good evening, everyone. Welcome, all of you. I think so. It's a new batch of test and discussion, and I think so. The last one was quite exciting for us as well. So the whole purpose of this test and discussion, as Dr. Vinayak would have told you, is that we want you people to come prepared for these topics. So it's basically trying to inculcate a sense of discipline in you, that you have to finish these topics before the test and discussion. Now, this time, the first time around, we are sorry that we sent you the questions a bit late, but from next time around, you will get the questions a day or two before, so you can solve them and you can come ready with your doubts. Now, whatever doubts you have regarding the topics today, we will keep around 15-20 minutes next time where you can clarify these doubts with us. Also, Dr. Vinayak would have pointed out that if somebody misses out on the test and discussion, we will share the recordings with you so you can go through them as well. And if you have any doubts, you can always ask us on the WhatsApp group also. So you had a session yesterday where Dr. Vinayak told you about part A, but I would just like to reiterate that, part A preparation is very different from your typical entrance exams which we have in India. So this is an amalgamation of surgery, a good amount of surgical anatomy, physiology. A lot of emphasis is paid on critical care as well. And, for surgeons to do orthopedics and orthopedicians to do surgery, that is a challenge in itself. Also, this year, we noticed that the pattern of the exam changed quite a lot. So this is an entrance level exam, and even an MBBS student with good surgical and anatomy knowledge should clear the exam. But this time around, the questions were a bit tougher, which is why the overall pass percentage globally was down. So it will be our endeavors that you are fully prepared for the exam till January. And for best results, we would recommend that you do this along with the QBank. If you're solving some other QBank, past test, MRCS, we are fine with that. But we would want you to practice questions of higher difficulty as well, which, we have kept around 20% of those questions in our QBank as well. So the TND plus the QBank would be your ideal preparation. For somebody who is totally new to preparation and they feel that their concepts or basics are lacking, the videos would be released by October end. We will start rolling out the first batch of videos. Almost 50% to 60% content will be rolled out, and then every week we will keep on adding more. There has been slight delay in the video processing on our side because of certain logistical issues. Okay. So with that background, I'm sorry I didn't introduce myself. I'm Dr. Rohan Khandelwal. I'm a breast cancer surgeon, and I have cleared my MRCS. I did that long time back, but I've been involved in training students for the Indian entrance exams as well as USMLE. And this is an interactive session, so I would like that you people ask your queries. Any doubts you have, please ask us so that we can make the session more interactive, okay? So starting with the first question, what do you call a breast malignancy that has histological presence of 2 or more cellular types, commonly a mixture of epithelial and mesenchymal components? Yes, I'm waiting for your answers.
Metaplastic breast cancers.
You have to please type it in the chat box, please. Please type it in the chat box. Please type it in the chat box, whatever you think is the answer. Okay. So some are going with A and some are going with C. So the correct answer here is metaplastic breast cancer. Metaplastic breast cancer is an entity which has components of both epithelial and mesenchymal types. And this is usually a triple negative breast cancer. We will talk about the molecular subtypes in some time. This is a triple negative breast cancer. and this has bad prognosis. Metaplastic breast cancers usually have bad prognosis. They don't respond well to treatment and to chemotherapy. Now, I would like to cover the molecular subtypes here. Let's do a question and then I'll tell you about the molecular subtypes. This is not there in your paper. I've included this because this is a very hot topic these days, the molecular classification of breast cancer. A lot of the treatment is dependent on the molecular classification itself. So review the following statements regarding molecular classification, and we will do a true and false. So everyone, you can just write true and false. First statement, it is based on gene expression profiling, true or false? It is based on gene expression profiling, true or false? So correct, this is based on gene expression profiling. Luminal A is the most common type and has the best prognosis. This has been asked many times, true or false? Two is also true, correct. Two is also true. This statement has been asked many times in the exam. Basal or triple negative breast cancer initially shows good response to chemotherapy. So you people got misled by my metaplastic statement. So metaplastic breast cancers don't show good response to chemotherapy, but otherwise triple negative breast cancers, and I want you to make a note of this, triple negative breast cancers show the best initial response to chemotherapy. It's just that they tend to recur. But triple negative breast cancers, barring metaplastic breast cancer, show excellent response to chemotherapy. Claudin low type expresses cytokeratin 5 and 6. So this is false. I'll tell you about this. And luminal B can either be HER2/neu positive or negative. This is a true statement. So the molecular classification, this is the molecular classification of breast cancer. And this is based on gene expression profiling. Okay. Now the question which has been asked, that the most common type is luminal A. Luminal A is the most common and it has the best prognosis. It is ER/PR positive, HER2/neu negative. There is low Ki67. Ki67 is a proliferative index marker. Okay, I'm sure all of you are aware of ER and PR, or do you want me to elaborate on this as well? Is everyone aware of estrogen and progesterone receptors? Hello. Okay. All right.
Guys, you will have to talk and you can unmute yourself and also use the chat to answer, please.
Okay, I'll tell you about ER and PR. So whenever we diagnose breast cancer, we do immunohistochemical markers. We do IHC markers. IHCs, immunohistochemical markers. And in the immunohistochemical markers in breast, we do 4: ER, PR, HER2/neu, and Ki67. ER, PR are estrogen and progesterone receptors, and these are nuclear receptors, right? So if you see a slide and if you see the center of the cell is brown, like you can see here, if the center of the cell is brown, that means ER and PR are positive. And that means that this tumor is growing because of estrogen and progesterone. It is an estrogen and progesterone dependent tumor. And if ER, PR are positive, that's a good sign, right? That's a good sign. HER2/neu, on the other hand, is a membranous receptor. And HER2/neu, you can see if HER2/neu is positive, the outside of the cell, the membrane of the cell will be stained brown. whereas the center of the cell is going to be empty. And presence of HER2/neu makes it a more aggressive tumor. Okay. Ki67 is a proliferative index marker, and higher the proliferative index marker, more aggressive is the tumor, more fast growing is the tumor. So these are the 4 molecular tests, or the IHC, which we do in all breast cancers. Now, luminal A is ERPR positive, HER2/neu negative. This is the best possible subtype and the most common. Almost 65% of breast cancers are ERPR positive. Now, luminal B can either be ERPR positive, HER2/neu negative, so like luminal A, but the differentiator is going to be high Ki67. Okay, or luminal B can be triple positive. All 3 can be positive as well. You can have HER2/neu enriched, where ERPR is negative, HER2/neu is positive. Basal is triple negative, where all 3 are negative, and basal or TNBC is the most aggressive. It has the worst prognosis. But I told you it responds well to chemotherapy, right? And the basal type of tumors will be positive for cytokeratin 5 and 6. Whereas there is another triple negative type known as claudin low. This is also triple negative, but this is cytokeratin 5 and 6 negative. Of course, this much detail has not been asked in MRCS, but the molecular types have been asked because these days the treatment is highly dependent on the molecular subtypes of breast cancer. So I hope the molecular subtypes are clear to everyone now. Even in this year's MRCS exam, there was a question from the molecular subtypes, which is why I wanted to explain these to you. Is this clear? Will you be able to answer questions regarding this? Perfect. All right. Perfect. Moving on to the next question. This is a very common question. So usually what happens is that this year also, and the general trend is that you will get at least 3 to 4 questions from breast disorders, at least 3 to 4 questions, out of which usually 1 is from the diagnostic aspect, 1 is from benign breast conditions, and 2 are from cancerous conditions. Okay, so sometimes 2 can be from benign and 1 can be from cancer. So minimum 4 questions you get from breast disorders, and this is a very common question which you get. So please read the question and tell me the answer. Okay, right. So majority of you are correct. Majority of you are correct. Let's look at the options now. So a 35-year-old with bilateral brownish discharge that is only visible on squeezing. So always remember that suspicious would be spontaneous discharge. Right? Spontaneous discharge is the one which is dangerous for us. Right? So spontaneous nipple discharge we should be concerned about. On squeezing of the nipple, if brownish discharge is coming, not very dangerous. 45-year-old with unilateral serous discharge that is spontaneous, yes, this is a cause of concern. Lactating mother who notices bloody nipple discharge that is spontaneous. So a lactating mother can have slight blood tinged discharge when probably the baby bites the nipple, or there can sometimes be some inflammation that can give rise to bloody discharge. In a lactating mother, not very significant. Greenish discharge is a sign of duct ectasia. This is the most common pathological cause of duct discharge. This is duct ectasia. Again, this is non-cancerous. And milky discharge with irregular periods. In a 27-year-old, this can be because of increased prolactin, and this is also not suspicious for a malignancy. So here the answer is going to be B. Now, one more question which you people need to understand is a very common problem in UK is duct ectasia. And duct ectasia, the patient will come with greenish discharge, or the patient can have inflammation and periareolar sinuses. Now, if you are getting a patient with periareolar sinuses, she's perimenopausal, there is duct ectasia, what kind of antibiotics would you use? That is my question to you. So what antibiotics would you use? Right, so that is where the difference is, and that is where people go wrong. So if it was a lactational breast abscess, we use amoxi plus clavulanic acid, right? Or you're going to use cloxacillin. So for a lactational breast abscess, your answers are absolutely right. But in duct ectasia, it is aerobic plus anaerobic infection. So you would end up using amoxi plus you will use metronidazole. Here you have to cover for anaerobic bacteria as well. So it is aerobic plus anaerobic infection, and that is what I want you to remember. If they are asking you the antibiotics for a lactational breast abscess, amoxiclav is fine, but for duct ectasia, you have to use aerobic plus anaerobic cover. That is something which I want you to note down, please. So this we've already discussed. The next question is, which of these markers can be used to differentiate superficial spreading melanoma from Paget's disease of the breast? Okay. So majority of you are correct. It is S100 positivity. Melanomas are going to show S100 positivity, and that is what can differentiate it from Paget's disease. Okay. Paget's disease, S100 positivity can be there. Can you tell me what are the other immunohistochemical markers for melanoma? What are the other immunohistochemical markers for melanoma? So S100 is one. Milan A is another one. Very good, Bhagwati. Is it Bhagwati? I'm sorry. And HMB 45. Very good. Good. Sana, HMB 45. That is correct. So these are the immunohistochemical markers in a melanoma. So this can help us in differentiating it from Paget's disease, right? This can help us in differentiating it from Paget's disease of the breast. There is one more question which was there regarding Paget's disease of the breast. Anyways, we'll talk about it. We'll discuss it in the course of. In which breast lesion would you see pagetoid pattern of intraepithelial spread? This is a slightly tricky one. So D is the correct answer here. It is lobular hyperplasia with atypia is where you see pagetoid pattern. And this also shows loss of EC adherence. So this is very important. This has been asked. It shows loss of EC adherence. And you should also know that LCIS now is no longer in situ. It is no longer in situ. According to the new classification, it is considered as a risk factor for breast cancer now. It is considered as a risk factor for breast cancer. Another thing is regarding ILC, invasive lobular cancer. One more thing which has been asked, of course, there's loss of EC adherence. In invasive lobular cancer, they've also asked that you get a single file pattern of spread. Single file pattern is that the cells are arranged one after the other. And these cells are also signet ring cells. These cells are also signet ring cells. So these are some points which you should know regarding lobular hyperplasia, lobular carcinoma in situ, and invasive lobular cancer where single file pattern is seen. So which of the following is not true regarding Paget's disease? It is associated with tumor masses that are usually ER/PR positive. Lesions can be mistaken for eczema. Malignant Paget's does not cause the basement membrane, and Paget cells can be found within cytological preparations of the exudate. So let's do true and false here. Let's do true and false. Are associated with tumor masses that are usually ER/PR positive. This is also false. This is also false. The tumor masses which are associated with Paget's disease are usually ER/PR negative. They are usually ER/PR negative. Okay. Lesions may be mistaken for eczema. This is true, but this is usually unilateral. Eczema is usually bilateral. Malignant Paget's do not cross the membrane, basement membrane. This is also false. So please, you should note down that majority of the Paget's disease are DCIS. So in majority, they don't cross the basement membrane, but a minority of Paget's disease can be there with invasive ductal cancer as well. And there it can cross. So for this question, there are two false statements which are there. Paget cells can be found within cytological preparation of the exudate. They can be, but it is very uncommon, which is why the diagnostic modality is to do a punch biopsy of the nipple. We don't believe in scrape cytology. We do a punch biopsy of the nipple. So for this question, there are two false statements which you should know about. So you have been called to provide surgical consult on a patient admitted to the geriatric ward for pneumonia. Her left arm has purple patches with subcutaneous nodules. She gives a previous history of mastectomy and axillary irradiation 15 years back. I think so. This is a straightforward question which has been asked multiple times in the exam. That's correct. You people are correct. This is a lymphangiosarcoma. Can somebody tell me what is the syndrome known as? Of lymphangiosarcoma and long-standing lymphedema. What do we call this syndrome? Very good. This is known as Stewart-Trevi syndrome. Excellent. This is Stewart-Trevi syndrome. This has also been asked multiple times. So after 8 to 10 years of long-standing lymphedema, this is Stewart-Trevi syndrome, which is lymphangiosarcoma and long-standing lymphodematous limbs. So one more thing which I would like to highlight, and me and Dr. Vinayak were discussing this, that in MRCP, they've already started asking image-based questions. So it's just a matter of time with new computer-based centers developing for MRCS. It is just a matter of time that image-based questions start in MRCS as well. So you should be well versed with images as well, because you don't want to be caught surprised if they start asking images from the next exam. Your pathologist quizzes you with questions on the breast biopsy slide. Identify the pattern. That is correct. Very good. This is a cribriform type of DCIS. DCIS, ductal carcinoma in situ, and you can have comedo and non-comedo. Comedo ones are more aggressive, and these comedo are usually ER/PR negative. Non-comedo are papillary cribriform, and cribriform, you get this cookie cutter-like appearance. You get these cookie cutter spaces in the ducts. So you get these cookie cutter spaces in the ducts. That is the classical finding of cribriform DCIS. So Dr. Sylvia is a leading researcher. She is volunteered to teach students, and she has a question for you. BRCA1 and BRCA1 and BRCA2 are Again, a straightforward question asked multiple times. These are tumor suppressor genes, that is correct. And we should know that BRCA1 is on which chromosome and BRCA2 is on which chromosome. BRCA1. BRCA1 is on which chromosome? Chromosome 17, and BRCA2 is on 13. BRCA2 is on 13. That is absolutely correct. That is correct. BRCA1 on 17, BRCA2 on 13. You should know the indications when to do BRCA testing. This question has also been asked occasionally in the exam. When do we do BRCA testing? So we do BRCA testing if there is BRCA mutation in a blood relative, if there's a personal history of ovarian, fallopian tube, or primary peritoneal cancer. For patients with breast cancer, if one or more relatives have been diagnosed with less than 45 years, personal history of bilateral or triple negative breast cancer, or male breast cancer. For patients without a personal history of breast and ovarian, if you have first degree relatives with ovarian and breast cancer, at least the breast cancer should be less than 45. So these are the patients where we first do genetic counseling and then we do genetic testing in these patients. So which structure is classically considered to be the medial-most limit of level 3 dissection? Okay. So Halsted ligament is the correct answer. Let's do what is the superior boundary when we are doing axillary clearance? What is the superior boundary? Superior boundary is the axillary vein. We don't go above the axillary vein. Okay, correct. Inferior boundary is the angular vein. Inferior boundary is the angular vein. That is correct. Medial boundary, we've just discussed, is the Halsted ligament. And the lateral boundary is the thoracodorsal pedicle. Thoracodorsal pedicle. So these are the boundaries of axillary clearance. When we are doing a clearance, we remain within these boundaries. These you should remember. This is also correlation with anatomy, and this question has also been asked multiple times. There is a 60-year-old lady with a 4 centimeter mass in her right breast, which is a small size breast. So let's say it is a 32A. It is a very small size breast, and there is a 4 centimeter mass. Imaging and core biopsies reveal it to be a DCIS and negative lymph nodes in the axilla, which would be the appropriate treatment plan for this patient. Okay. All right. Right. So first of all, you need to understand this is DCIS. DCIS is ductal carcinoma in situ. It is an in situ tumor, means it's not invading the muscle, the basement membrane. I'm sorry. It's not invading the basement membrane. So if it's not invading the basement membrane, there is absolutely no role of chemotherapy. There is absolutely no role of chemotherapy. So this option, these two options are out here. Now, I categorically mentioned it's a 4 centimeter lesion in a small sized breast, right? In a small sized breast. Had it been a 36CD, a large breast and a 4 centimeter lesion, you could have done a wide local excision and a sentinel lymph node biopsy. But because it's a small breast, that is not going to be feasible here. So now the option is between mastectomy, reconstruction plus sentinel, or just mastectomy and reconstruction. So if it is just a low grade small DCIS, we don't do sentinel. But if it's a large palpable, this DCIS is a palpable DCIS. So if it's a palpable DCIS, we need to perform sentinel lymph node biopsy as well, because sometimes it has been seen that such big lesions can harbor a foci of invasive cancer as well. So A would be the best answer here. So Irene has just undergone a mastectomy for breast carcinoma. She's been told that she can have reconstruction surgery using the latissimus dorsi flap at a later date. While doing physical examination, you notice winging of the scapula. Which of the following restrictions will she have? So we want to highlight that this is how surgical anatomy questions are asked, right? So this is a direct, this is a correlation between core surgery and surgical anatomy. So in the MRCS exam, your surgical anatomy questions would be somewhat like this only, where there would be at least two level correlations. First, you need to figure out which nerve is injured, which muscle is injured, and then you need to know what is the mechanism of action of that muscle. So you people are correct. You people are correct. There will be pain around the shoulder, and because which muscle is gone? Which muscle is gone? No, it's not latissimus dorsi. It is serratus anterior. It is not latissimus dorsi. Winging of scapula is seen in nerve of Bell, long thoracic nerve, which supplies the serratus anterior, not the latissimus dorsi. Which nerve injury will you have numbness and paresthesias around the armpit? In which one would you have paresthesias around the armpit? Correct. Very good. This has also been asked. ICBN, intercostobrachial nerves. These are the intercostobrachial nerves. Intercostobrachial nerves. And these are the most commonly injured nerves when we are doing axillary clearance. Okay. So this I've already told you. ICBN will cause numbness, and this is because of serratus anterior. So what is the investigation of choice for inflammatory carcinoma of the breast? So I want you to understand that PET-CT will never be confirmatory. How can PET-CT confirm the diagnosis? So the diagnosis confirmation will only happen on biopsy. And we all know that for breast biopsies, the best investigation is a core needle biopsy, where we use a 16-gauge needle. A core biopsy is what clinches the diagnosis for us. Now, can somebody tell me that inflammatory carcinoma is as much a clinical diagnosis as it is a pathological? So you'll of course confirm the diagnosis of cancer on pathology, but clinically, if you're shown a patient, what will you see in inflammatory carcinoma? No. Evangeline, no. Skin involved with what? Skin involved with what? Correct. Pudiorange. No, there is no ulceration. Ulceration is not mandatory. Inflammatory breast cancer is when more than 1/3 of the breast skin has pudiorange or PDO. That is what we call as inflammatory breast cancer. And inflammatory breast cancer has the worst prognosis amongst all breast cancers. So can you tell me what will be the T stage here? Correct. I agree with you. It should have been T4D, but T4D option is not there because more than 1/3 of the breast skin is involved with PDO. Ideally, it should have been T4D, but T4D option is not there. So if T4D option is not there, we're going to mark skin involvement because there is extensive PDO, pudiorange, and we are going to mark T4B. Now, can somebody tell me why does pudiorange occur? What is the reason behind pudiorange? What is the reason? Correct. Involvement of the subdermal lymphatics. Very good. Involvement of the subdermal lymphatics, and it's a sign of skin involvement. That is also correct. Please answer this question. Yes, please answer this question. So again, like I said, a lot of correlation with anatomy. You get a lot of anatomy related questions in the MRCS exam. C is the correct answer. So you have a patient who's undergone a mastectomy and she has new onset weakness of the ipsilateral arm while pulling down on a cord and to adjust the window blinds at home. On examination, she has difficulty attempting to internally rotate an adductor arm. So this is which muscle which is causing a problem? Latissimus dorsi. And latissimus dorsi will cause problem when the thoracodorsal pedicle has been inadvertently injured in these patients. Okay. So nerve injuries and complications of mastectomy is a very important question which is asked in the MRCS exam. Again, a straightforward question, but asked multiple times. So there are two questions here, and I don't want you to make a mistake here. These are two very important questions. They are asking the most important predictor of 10-year survival. So they are asking about the prognostic score, and the most important prognostic score is the axillary lymph node status. There is no confusion regarding this. But if the question specifies what is the most important prognostic factor for metastatic breast cancer, for metastatic breast cancer, it is the ERPR status. Because if you remember, I told you that ERPR positivity is a good sign. It is a good prognostic sign, but it is more useful in metastatic breast cancers rather than curable breast cancers. So this question, I want you to avoid. This question is a wrong question. We are going to do away with the question. We will do other questions in place of this question. A 45-year-old undergoes a wire-guided excision and it turns out to be DCIS. Final pathology shows no invasion, but DCIS is involving the deep margin. What is the next appropriate step? Right, so correct. We will carry out a re-excision of the deep margin and we will do a sentinel lymph node biopsy. If it was a palpable mass, we will do a sentinel lymph node biopsy as well. We've already discussed this. Okay. Miss Lorraine Williams, while undergoing her annual medical checkup, was discovered to have a which, okay. So look, we have a margin which is positive. We have a margin which is positive. So when we have a positive margin, we have to re-excise it. We cannot leave DCIS or invasive cancer on a margin. We need to have negative margins. Negative margins for breast is no tumor at ink. So here they're saying that there is positive margin, deep margin. So we have to re-excise it. No tumor at ink. And because it's an intermediate grade, if it was a palpable DCIS, we have discussed just earlier on in the TND that for palpable big DCIS, there is no harm in doing a sentinel lymph node biopsy as well. Is that clear, Joshua? So this is another additional question. I just want to include a few questions regarding benign breast diseases as well, because benign breast diseases are also, yes, if it was non-pal, correct, Joshua, that is correct. But they did a localization and removal. Now, ideally, that should have been mentioned. I completely agree with you. Let's assume that they have mentioned it to be there. If it is not mentioned, right, I made that question. So that's why I wanted you to mark sentinel lymph node biopsy. So I should have mentioned that it was a palpable lump. If they don't mention, then you will just mark re-excision of the deep margin. Yes. Breast mouse, what is the diagnosis? Correct. So which of the following will be against the diagnosis? Let's do a true and false. Let's do true and false. Grossly appears to be well circumscribed with firm consistency. True or false? This is true. Ranges from size 1 to 5 centimeters. True. More than 5 centimeters is known as giant fibroadenoma. Excellent. Excellent. Capsule is well defined. True. Both glandular and cystic components are found. True. It is not monoclonal. It is not monoclonal. Right? There is proliferation of the terminal lobular unit, and these cells are polyclonal in nature. They are not monoclonal. They are polyclonal in nature. That is what I want you to remember. They are. Absolutely. Yeah, that's all right, Shraddha. You can drop out. You can listen to the recording. The recording will be shared. You can drop out. Take care. Please take care. This is also a very common question which is asked in the exam. A 40-year-old lady comes with a mobile lump in the upper outer quadrant, and this is found out to be a cystic lesion. It's a cyst, a breast cyst, and this cyst is aspirated. It was a big palpable cyst, and this has been aspirated. Which of the following is the true statement? Very good. Excellent. A is the correct answer. This is asked quite frequently. In fact, even in your part B exam, they ask this question quite a lot, because what happens in India or in the Southeast Asian countries, it is our tendency that no matter what we aspirate from the breast cyst, we send it for cytology. But the guidelines say that if it is bloody, then only we send it for cytology. If it is bloody, then only we send it for cytology. Okay. Otherwise, we don't send breast fluid for cytology. So this is what cysts look like. This is what breast cysts are going to look like. Okay. Which tumor shows maximum pathological complete response to NACT? NACT is neoadjuvant chemotherapy. Which tumor will show best? Yes, sure. Yeah. For the previous question, this is the explanation slide. So there is no need to send the cyst aspirate for cytological examination until and unless it is a bloody aspirate. And if you have thickened, multiseptated, high vascularity cysts, those are the complicated breast cysts which you should know about. Yes, please, this question. Which of the following tumor shows maximum pathological complete response with neoadjuvant chemotherapy? I told you which tumor responds well to chemotherapy. We discussed this. Look, why I'm re-emphasizing on this is this year also this question was asked, molecular classification. This is now forming the basis of breast cancer treatment. So everyone should be aware of molecular classification. The correct answer is triple negative. Triple negatives show maximum response to chemotherapy. Yes, please. Answer to this question, 6 into 4, postmenopausal single palpable lymph node. First, tell me what will be the clinical stage. What is the clinical stage of this patient? Very good. Correct. T3N1. So T3N1 classifies as what kind of tumors? Excellent. Excellent. Correct. These are locally advanced breast cancers. Very good. Locally advanced breast cancers, how do we manage them? Correct. Neoadjuvant chemotherapy. We do neoadjuvant chemotherapy followed by MRM. Very good. So this is also frequently asked. This is the definition of locally advanced breast cancers. Locally advanced breast cancers are T3, N1, M0, any T4, any N2, any N3 with M0. And we have to give neoadjuvant chemotherapy here, followed by surgery in these patients. Followed by surgery in these patients. This is what I told you for invasive lobular cancer. If you remember, infiltrating lobular cancer, you get the single file pattern and you will get signet ring cells. The cells are arranged one after the other. We discussed about E-cadherin here. E-cadherin mutations can be there. So those were the slides which I wanted to discuss with you today. Some extra questions which were recently asked in the exam. We've tried to include similar questions. Of course, we can't include same questions because of a non-disclosure clause, but we've included similar questions so that you people are better prepared for the exam. If you have any queries, please feel free to ask your queries. Once I'm done, then Dr. Vinayak will take over. First two questions. This was the first question. What do you call a breast malignancy which has two or more cellular types, a mixture of epithelial and mesenchymal components? This is known as metaplastic breast cancers, and metaplastic breast cancers are also triple negative breast cancers which have poor prognosis. The second question is a very classical MRCS question where they give 4 or 5 options and they ask you which is the most suspicious case of nipple discharge. So we always have to consider spontaneous nipple discharge is going to be the most suspicious. On squeezing nipple discharge is not important for us. So in this case, the answer was a 45-year-old with unilateral serous discharge. You also had a 30-year-old lactating lady with unilateral bloody discharge, but lactating ladies can sometimes have bloody nipple discharge when the child bites the nipple or because of trivial trauma. So you will not consider a malignancy in that case straight away. Any other questions, please? No, level 3 is not supraclavicular. No. Level 3 is not supraclavicular, please. So this is the pectoralis minor. This is the pectoralis minor. This is lateral. This is medial. Level 1 are lateral. Level 2 are behind. And level 3 are medial to pectoralis minor. But level 3 are not supraclavicular lymph nodes. It is N3C if supraclavicular lymph nodes are involved. I think you were getting confused between the staging and the levels, Evangeline. Is it clear now? Is this point clear to you? So even when we do a level 3 dissection, these are the boundaries only. Boundaries are these only. Superior is axillary vein, inferior is angular vein, medial is Halsted ligament, lateral is thoracodorsal pedicle. Any other question? The question with the staging, okay. No. So of course, they will not ask you to assess fixity on just an image. It will be very difficult for you to comment on fixity just on the image. You cannot assess that just based on an image. These are the indications to do BRCA gene testing. The ones which are important, which you should definitely know, if there is a BRCA gene mutation in a blood relative, if one or more relatives have been diagnosed with breast cancer less than 45, bilateral breast cancer, triple negative male breast cancer, and if you have a first and second degree relative with ovarian and breast cancer less than 45. So okay, if there are no further queries, Dr. Vinayak, if you're there, please take over.
Yes,
Dr.
sir.
Vinayak is going to cover up a very, very important topic. At least 3 questions from 3 to 4 questions from medical legal aspects are asked. Now, this is something which we don't usually read in Southeast Asian countries. So some of the things are very unique. So please pay attention to it. This is a very important topic for your MRCS exam. All right. Thank you very much. I'll see you next week. If you have any further queries, you can always ask me in the WhatsApp group. Over to you, Dr. Vinayak.
Thank you so much, sir. Thanks for the great session. Okay, so guys, we'll be doing a very important topic. Sir told there are at least 3 questions which are asked, and now this is a topic which is kind of not very commonly covered in our curriculum, and so this is a topic which a lot of you guys find a little challenging. So we will be covering many important points in this testing discussion. There is a lot more to the functioning of NHS, professional behavior, medical ethics. Most of the concepts are covered in the MCQ bank as well. We have tried to be as updated as possible. So one of the best advantages of our resource is that we have been up to date with the latest legal updates as late as 2020 or 2000. So let's start with it. Let's start with the first question. Why obtaining consent, which of the following is not true? So the options: provision of translators is necessary if the patient doesn't understand the language. 2, any member of the surgical team can take consent. 3, enough time must be given for the patient to arrive at a decision. So this makes sense. Consent should be taken in a quiet room. All of the above. So which of the following is not true? I think this is a very easy answer. So the answer is obviously B. And any member of the surgical team cannot actually take consent. Ideally, only the operating surgeon should consent, as other members of the surgical team may not know the details. Regarding other aspects of consent, the consent is always taken in a quiet venue. Enough time is taken, right? And before taking the consent, you should ask whether you want somebody else to be present along with, so that they can take an informed decision. Translators are a must when the patient does not understand the language, and this is very important. Of course, this above scenario can have exception. And that is something which is very important in your part B. You will have scenarios like this. The operating surgeon is stuck in an emergency, and in case you are the registrar, you should inform that you are the registrar and the operating surgeon is stuck in an emergency, and that is the reason why you're taking the consent. And if you're not going to operate and you're not the concerned, you will have to inform the patient about this as well. So again, we are going to get into a very important concept right now, which is child abuse, and it's a very important part of medical legal aspect. I'll be covering this in a little more detail as well today. An 18-month-old boy has been admitted to the pediatrics unit with burns sustained while in care of his mother's. You are concerned that a non-accidental injury may have taken. So when you look at child abuse per se, which of the following is suggestive of child abuse? Is it bruising over shins? Is it injury consistent with history? Is it a mid-clavicular fracture? Is it rib fractures, or is it supracondylar fracture? I put this question intentionally because it's not very, it's a little ambiguous. So what is the answer for this question? More people to answer? So a lot of you have said D, and I think this is the right answer. But what kind of rib fractures would you see in a patient with a child abuse? When you look at child abuse, one of the biggest challenges you would say is evasive or changing history. The history keeps on changing, and there is always a delay. So one question which can come in this particular scenario is that you see a patient reports with burns The mother says the child has suffered this burns just a few hours back. And you see that there is pus oozing from the wound. Now, what does this tell you? What does that tell you? Now, this tells you that this burns is a cold burns. There's been a significant time gap between the actual burn and the presentation. The mother is lying about it. Again, so 2-3 points are covered over here. There is erasive or changing history, there is a delayed presentation, and there is no explanation or an implausible mechanism. So now this scenario, if it comes in your patient, so you know that the patient has been giving underlying. Another scenario which should come here in your exam is a situation where there is scab and the patient's mother says that the wound has been suffered now. It takes a few days for the scab to develop, at least 24 to 48 hours. And before that, the scab cannot develop, and that is very consistent with an evasive changing. So inconsistency between age of the burn and age given by the history. Inadequate supervision, such as child left in the care of an inappropriate. One very important thing, in fact, this was a question which I had put in one of the last TNDs, is lack of guilt about the incident. So if there is a scenario where the person shows lack of guilt, that means that that is very suspicious. Right? Often we assume that guilt occurs only when the patient, the mother or the father has had something to do with accident. Parents often tend to feel guilty about anything that happens to a child. You might have experienced it with your parents, or you might have experienced it if you are in a situation where you've seen parents, your own parents. So a person who's a psychopath, a person who does not care about the child, will show no guilt. You'll say, yeah, the child had this accident, and that is kind of obvious when I work in pediatric surgery. So I kind of know that, lack of guilt about the incident is very consistent. So when we see a patient of sexual abuse or a patient coming with, unexplained injury and the parent does not show any sort of guilt, even if one parent does not show any sort of guilt, we make sure that the police is informed and we leave it to the police to. So signs of child abuse, long bone fracture in a child who is not yet working. You see a 2-year-old with a fractured femur, that definitely is suspicious of child abuse. That means the patient has been beaten up. Single fracture with multiple bruises. You see that there's a fracture and there are multiple bruises around. It shows that there is something. Multiple fractures. That means that the child has suffered multiple injuries over a period of time. So what is corner fractures? Can somebody tell me what is corner fractures? Nobody? The fracture in the elbow or the limbs when the arm is twisted, it occurs metaphyseal injury. So this is a corner fracture. When somebody twists your arm, bullies in school might have done that to you, but that can cause a corner fracture. Good, Smriti. Metaphyseal fractures, yeah. Skull fractures in association with intracranial. Skull fractures are very rare. Intracranial injuries are very rare in children, and that is something you need to take care of. Posterior rib fractures. Posterior rib fractures. So when you compress a child, you will realize that after the child is shaken, you will realize that the 4 fingers of your arm actually compress the posterior rib. Anterior rib fractures are very rare in children. Posterior. If we go back to the question, if it says there are 2 options saying the rib fractures, anterior rib fracture and posterior rib fracture, posterior rib fractures. Supracondylar fractures of the humerus are very common in children. Bruising over shins. Any person who plays in the yard, any child who plays in the yard should have some bruises on his shins, and that is, I think, very normal for children. Injury consistent with history, absolutely. It makes a lot of sense. Midclavicular fractures are very common in children. So when it comes to burns, what are the bad burns? Cigarette burns, 1 or more rounded ulcers or erosions, which you can see over here. I'll show that to you. This is classical cigarette burns, and this is something which is very suspicious of childhood. Branding injuries, fork, spoons, shape of object. Now that is punishment. That is definitely a mistake. Motion burns of the buttocks and extremities. Dunking a child into scalding water. Glove and stocking distribution with a uniform depth of burn. When you splash water, the depth of burn is not uniform. When you immerse the child, which is common in child abuse, this is what is seen. So if you look at this is the zebra stripe. When you immerse a child in water, holding the child's skin is more sensitive to hot water, and your skin is not very sensitive. You dip the child in hot water. These areas where you see the zebra stripes are your places where you place your fingers. And this donut hole sparing when the child is dipped inside, you will realize that the buttocks touches the floor of the bucket. So the heat is not transmitted at that point and it affects the other parts. So this pattern, classical pattern, glove and stocking pattern, and the donut hole sparing and zebra stripe is very classical of child abuse and burns. A 7-year-old boy is brought after a road traffic accident. He sustained a blunt abdominal injury, a fractured pelvis, and a left kidney hemopneumosis. He is accompanied by his father, who is unscathed. The family are Jehovah's Witnesses. The child isn't great. The father states that he would rather see his child die than receive a blood transfusion. What is the correct punishment of this child? In our part of the world, we'll say, oh, it's your child, your headache, if you don't give consent, we can't. What would you actually do in a setting UK? A, accept and respect the child's father's wishes. Would you do that? Discuss the situation with the father, but manage the child using ABC principles and transfuse the child with group O negative blood while you results await. Manage the child according to ABC first principles and use a non-blood product while seeking urgent legal advice. So this is 2 a.m. So imagine you are at 2 a.m. Telephone the elders of the father's coming to schedule a meeting. Telephone the on-call trust barrister to make the child award. So almost all of you have given the wrong answer. When you guys make a mistake, I feel validated. Okay, there is a point when we are doing the session. We are here to teach you something. Okay, so when you answer everything right, I think, oh my God, these guys are super brilliant. Maybe they don't need this. But yes, the answer is not C. The answer is B. You should discuss the situation with the father, but manage the child using ABC and transfer the child with group O negative blood for the waiters also. So here you follow what is called as the Children's Act 2005. The parents are important. The parents' wishes should be respected. But here you use something called as a consent form 4 and also according to the Children's Act 2005. It makes a lot of sense to discuss and inform the parents, but their permission is not required. According to this Children's Act 2005, the best interests of the child are paramount in all decisions regarding children. If the child is less than 12 and in an older child that lacks capacity, medical treatment cannot be performed without parent or guardian consent unless for life-saving treatment where the doctor can act in best interest of the child and in this case can administer blood transfusion. If the child himself says that I am very clear that I don't want blood transfusion, then you can actually go ahead and refuse blood transfusion. But now that is not the situation. And there is no specific age regarding this particular concept. We'll be discussing further at what age and how do you determine whether a child is competent to take decisions of his own. In the UK, the patient is more important than the father, or the patient is more important than the state. Even though a child is considered as an adult if they are above 16, if the child is competent, like what we call as a Gillick competence, we'll be discussing this further, the child can take a decision. But here, the child is too young, 7 years old. The child cannot take any decision on his own. And here you use ABC principles, but here the patient isn't a great foot shop. You don't use any non-blood products, you transfuse for it. If it's a non-urgent situation, you can telephone the elders of the father's community, or you can, there is a, Jehovah's Witness, a licensed trust in every hospital. You can license with the lawyer over there, or license with the, the counselor over there who will explain the situation to the father. But this is an emergency situation, and you should go ahead and transfuse according to ABC. So, does anybody have a doubt here? So, Vasumati, fluids are first line management. So, do you want to, explain this to me a little more clearly? Please unmute yourself. Dr. Vasmati? Okay. So here you have to follow ATLs. ATLS says that only in grade 1 and grade 2 shock we will use fluids as first line management. In grade 4 shock, blood is the first line management. Please be very clear on that. There's an on-call trust barrister to make the child award of the court. If they feel that the child is not capable, the parents are not capable of making decisions, there is a lawyer in the hospital who can, petition and file a petition to make sure that the child can be made a ward of the court so that the parents don't take decisions for the child. And this is done in very rare cases when you feel that the parents are not fit to take any sort of decisions. That is not going to be applicable over here. So you're the court trainee and you just reviewed a 30-year-old patient on the ward who's died following an emergency operation for a bowel perforation. You're required to fill in the death certificate in the bereavement office. As soon as you're able to. Cases should be referred to the coroner in England. It's usually Her Majesty's coroner. Now it's His Majesty's coroner. Now we have a king over there. So they include which of the following. Death from a bowel perforation, would you prefer? That's pretty common. You don't need to. Death from a notifiable disease, it is meningitis. Death from AIDS or HIV-related illness, do you think so? Death in a patient under 50 years of age. Nobody under 50 years of age should die. So do you refer it to the coroner for suspicious death? Death related to industrial or occupational disease in former employer. EBBE. More answers, please. More answers. I want more participation. There are about 30 of you over here. Let's see how you. EA. So we got a varied explanation. So let's see what is the answer. The answer is E. So death which should be referred to the coroner are a doctor did not treat the patient during their last day. So you don't have any doctor who has seen the patient. Doctor did not see or treat the patient for a condition from which they died within 28 days of death. Cause of death was murder. The cause of death was sudden, violent, or unnatural. The cause of death was an industrial disease of the lungs, such as asbestosis. The death may have occurred in any circumstances that may require investigation. In fact, any sort of industrial accident is something which you should be referring it to the death in the hospital should be reported if there is any questions of negligence or misadventure. The death happened before a provisional diagnosis was made and a GP is not willing to certify the cause. Any anesthetic death should be reported. Any death in the prison should be reported by the governor of the prison, irrespective of what the cause of death is. The police should report a death to the coroner when they found a dead body, the death is unexplained, or they are suspicious about the death. Coming back to the causes. The cause of death from a bowel perforation is very well known. And a cause from a notifiable disease should be referred to the Center Communicable Disease Control, the consultant, and it does not need to be referred to the coroner. Age does not affect when a case should be referred to the coroner. It is only if you find the death. 50-year-old can die of a natural heart attack. It is not suspicious. AIDS or HIV-related illness is not a cause of death. Be referred to the. Any doubts over here? You can unmute yourself and ask. If you don't have any doubts, I'm going to proceed. Am I going at the right pace, or do you want me to slow down or hasten it? Guys, I demand answers. So let's go ahead. Rita Warrior is a smart 14-year-old girl who is requested an abortion for an unwanted pregnancy. She does not wish her parents to know about the procedure. So what is meant by genetic competence and in this particular situation? A, B, C, D, or E. If I do have some Indian parents, I think they would say E. A lot of Indian parents over here, let's see. Child of any age can consent to the treatment if she or he understands medical treatment proposed. Any C? So E is typical Indian parents. I think C and D would be atypical nice Indian parents. I see a lot of C and D is coming. But what is the answer in reality? Again, medical legal aspects of surgery is an area which is quite confusing because what necessarily appears right or logical may not be the right answer and may not fit into what courts in the UK see as logical. So here you should have your concepts very clear. Just purely applying logic always does not work in this. So I will explain what is Gillick competence. So the answer is obviously B. A child can consent to treatment if she or he fully understands the medical treatment provided. Gillick competence states that above 16, anyone is considered as an adult. But if the child is capable of taking a decision, if he or she is below 16, they can make an own decision. They can take their own consent if and when the child achieves sufficient understanding and intelligence to understand fully what is proposed. If you say that the patient needs surgery, the child can refuse surgery. If she says, yeah, I understand that I need surgery, but my religious principles, or I feel that I don't need surgery. Of course, you can overrule it if the surgeon feels or the doctors feel that the child is not illegal. If they feel that this decision may lead to death or severe injury, and this can be overruled by the court of appeal. If the child is not really competent, then someone with parental responsibility and capacity can consent for them. If the parent refuses to consent for, again, a decision which is in the best interest of the child, this decision can be overruled by the courts, or even you can use consent form 4. We will be discussing what is consent form 4. So in Gillick competence, do you have any doubts? So this is Victoria Gillick. Does anybody have an idea? If anybody has some knowledge about this particular case, I think they can open up and tell me who is Victoria Gillick, and I would be willing to give them a chocolate next time I meet them. People who are not enrolled, let's put a bigger this thing. You get a good discount on the testing discussion if you're able to answer this question. Who is Victoria Gillick? Why do we have a name? Unfortunately, Victoria Gillick is a person who is not very proud of the Gillick competence being named after her. She was an activist in England who wanted to make sure that young girls don't get access to birth control because she felt that it's against Christian principles and it is against family way of life. So she was an activist whose name was eponymized against her wishes in that famous rule by the House of Lords and the courts. So she did not want this to happen, but it happened anyway. And I personally am in support of Gillick competence and children taking control of their own bodies. People might differ with me, but that's me. 89-year-old Lalita Bansal has Alzheimer's and severe dementia. She is on the negative list for the excision of an ulcerated squamous cell carcinoma. Her son Naveen Bansal shows that he has a lasting power of attorney, LPA, and he will be able to consent to the treatment on a whim. Which of the following statements regarding LPA and consent is? Let's see the answers over here. Health and welfare LPA to be made on the donor's medical care, daily care, and living arrangements. Okay, let's see if it makes sense. Health and welfare LPA comes into effect as soon as it is registered. I don't think so. Let's see. Guys, you have to answer this question. Nobody's answering this question means it kind of makes this entire session redundant. You are supposed to answer. Now I'm saying a lot of the right answers. LPA can be validly made by anyone over 16 if they have the mental capacity. LPA cannot be validly made by anyone 18 or over. If there's more than one attorney registered, they must both give consent for medical care decisions. Does E make sense? LPA cannot be made validly by, we have a couple of C's. Oh, E, C, E. Okay. Guys, I want you to read option C, D. So very clearly. Anyway, the answer is what the initial voice told, it is up to me. So an LPA is a legal document that can be made by any person 18 or over. So a lot of you who wrote 16 or over, they are wrong. It cannot be made with 16. It is made in anticipation of loss of mental capacity. A 19-year-old boy who's been diagnosed with multiple sclerosis, he knows he's going to get dementia. He can make an LPA in anticipation that he is likely to lose his mental decision. And he can authorize his parents, brother, or anybody to take decisions for him. It can be made by a person who's been diagnosed with Alzheimer's as long as the time of making the document or creating the document, they are of. It must be registered with the Office of the Public Guardian. An attorney or attorneys are appointed to make decisions over either property, financial affairs, health and welfare affairs, or both, and must act in the donor's best interest when deciding upon medical treatment. The attorney here is not a lawyer. The attorney is any individual. It can be family, it can be friends, it can be a lawyer, it can be anyone, as long as they are trusted by the people. There may be one LPA, there may be two, there may be three. The terms of LPA can vary. It does not mean that all of them have to sign. It can be either or. Like it can be, the terms of the LPA can mean that, both of them have to sign, that means both of them have to sign. If it means that only one of them, either of them has to sign, then it can be either. Now, the lasting health and welfare family economy LPA is very different from a financial LPA. The financial LPA is an LPA which is made for a person to take financial decisions. And that comes into effect as soon as it is registered in the OPG, Office of the Public Guardian. The health and welfare LPA never becomes valid till the donor loses capacity to make such a decision. As long as he has a decision-making ability, he can change the LPA, remove the LPA, remove the attorneys, whatever he wants. But once he loses his capacity to, take decisions, LPA comes in. Cole Williams is a banker, mental health disorder. He requires an urgent laparotomy, incapable of consent. So the following allows you to proceed to the theatre. Yeah, let's see. B, C. And it's a life-saving procedure, man. More answers, please. Use logic. Omar has taken the hint. Achyut has taken the hint. Sandeep has not taken the hint. More answers, please. Karthik says C. I'm proud of myself because I think I'm the master of distraction. Give you some clues to mislead you. And I told you to use logic. But as I told you, don't use logic when answering questions. There is a lot of logic involved, but you have to be very clear with the rules as well. Technically, this is a life-saving procedure. Consent is always required. But here, the consent is not signed by the patient or the attenders. Consent is signed by the surgeon. So technically, it is no consent, but it's called as a consent form 4. So answer B is the one which is right. So let's see what is consent form 4. So written consent is still required. And this consent is called as a consent by proxy. So if there is a question, there is question in the question bank which says there is a consent by proxy. Consent by proxy is essentially same as consent form 4. The Mental Health Act concerns treatment and rights of people with a mental health disorder. But here in a life-saving treatment, when it is not concerned itself with Mental Health Act, it is related to consent form. So let's look at what is consent form. Again, coming to what is consent. Consent means a patient must give permission. When I say patient, it means a patient or a person themselves. It is not the mother, father, wife, the same. It's not like in South Asian countries. It is the person must consent to the treatment. Consent should be done after the basis of an explanation by the clinician. Consent from a person is needed regardless of the procedure, whether it's a physical examination, organ donation, or something else. In very small cases, such as an examination of the abdomen, you don't need a written consent, but it is called as implied consent, where you say, can I do it? Yes, if they say yes, they can do it, they can. But if it's even a minor procedure which involves cutting the skin, this does not, is not done. So Omar has asked me a question: is it valid in India too? Yeah, rules in India are very, obtuse, abstract. We don't have proper legislation regarding this. And in India, consent often means consent to the attender. But yes, consent actually means consent from patient only. So you should make sure that you take the patient's consent before a hernia. So for the consent to be valid, it must be voluntary and informed, and the patient must have the capacity to make a decision. If the patient makes a voluntary, if an adult makes a voluntary and informed decision and refuses a particular treatment, even if it's a life-saving procedure, that decision must be respected. If the patient does not have capacity, the patient is in dementia, if the patient is in septic shock, then you go for consent form. If there is an LPA, the LPA can actually take decisions. LPA not taking a life-saving consent, it's a very gray area, but again, that depends on whether the LPA is valid or not. Discuss the situation of the patient's friends, relatives before making the decisions. Their decisions are important, but surgeon and the consultant, you have the power to sign the consent form for. Their opinions are taken into consideration, but the decision is taken by the surgeon and the consultant. They're taking in mind the best interest of the patient. Consent form 1, patient agrees to an investigation or treatment. Consent form 2 is patient or parental response, parent or a guardian taking, agreeing for investigation or treatment for a child or a young person. Consent form 3 is patient or parental consent for a procedure like a local anesthesia removal of a lipoma, that is consent form 3. Consent form 4 is signed by the consultant for patients who lack capacity to consent to investigation or treatment. Any doubts at this point of time? If you have any doubts, this is a very, very important concept. I want you to unmute yourself, ask me the questions right away so that we can proceed. Guys, do take this seriously. These TNDs are very valuable resources. They make your life easy. And I want you to make maximum use of this by asking me doubts. Okay, so Evangeline has asked, you don't understand the difference between 1 and 2. 1 is a patient, 1 and 2 are for procedures in which consciousness is lost. Endoscopy, patient is sedated. General anesthesia, patient is sedated, is in losing his consciousness. Consent form 3 is for local anesthesia procedures or for procedures like catheterization where you may not, the procedures where consciousness is not impaired. All local anesthesia procedures, all procedures where consciousness is not impaired, it's consent forms. Do you understand now? Have I made myself clear? Yeah, okay. Shall we proceed? Matthew Bennell needs an emergency splenectomy, 17-year-old boy. Which of the following is the most appropriate action regarding consent for surgery? Contact the patient, parents to seek consent. He's unconscious. Yes. Unnati, yes, Unnati. You guys are right. It is consent by proxy. Again, same concept, consent form. You guys are right. So the age is a confusing factor here. There is some doubt which has been asked me. 1 minute. Competent adult not willing for a life-saving treatment. Yes, Ranjit, a competent adult, if not willing for life-saving treatment, he will be left alone. Definitely will be left alone. We don't transfuse blood to a elective neurosurgical procedure in a Jehovah's Witness unless he consents. Even if that means on-table death, we don't transfuse blood because he has mentioned it prior. Same situation. Okay, we have Gregory. He's been brought to the emergency room. He's injured himself. He's confused his head. He appears to be confused and disoriented. The policeman asks you to obtain a blood sample to test for blood alcohol, but you can see that Gregory is not capable of giving consent for this at present. What is the most appropriate action in these circumstances? Take a blood sample now and wait till Gregory can give consent. Take a blood sample, but wait till Gregory is alert and oriented before testing, regardless of his willingness. Take a blood sample, immediately give it for analysis in a medical legal case. Take a consent from emergency contact and testing. Inform the policeman that you can only withdraw the blood once Gregory is able to consent to it. It's a very difficult question. You will not be able to use logic, because logic says something and what you want says something. Logic for me says C. Take a blood sample, give it an analysis as is a medical legal case, but the answer is obviously different. So the answer is A. Take a blood sample now and wait till Gregory can give consent for alcohol concentration. So this is according to Police Reform Act. It is no longer necessary to obtain consent from unconscious to take samples. However, the sample cannot be tested until the patient regains confidence and provides. Now you will ask me, the next line, it will tell, if a patient refuses to consent, he will be liable for prosecution. Again, so Gregory King needs to be sampled. His testing can wait, but if he refuses consent, he can be prosecuted. So you might ask me, what is the logic in this? Unfortunately, this is the law. You need to understand it. You need to follow it. And that is the take-home message from this test. You get the point? Answer is A. He needs to be sampled, but his testing can wait. Any doubts over here? If there are no doubts, I would like to proceed.
Sir, I'm having a doubt.
Yeah, absolutely.
Sir, what if the patient's condition is because of some other disturbance? Could it be some electrolyte disturbance or something else?
Hey, you can check everything, but alcohol testing cannot be done.
Okay.
You can check everything, but alcohol cannot be done. Okay. But at the same time, if you feel that, the alcohol, you are having an undiagnosed situation. Okay. Patient comes to you in coma, you don't know what is the thing. You need to test for drugs. At that point of time, you can test. But here, the cause of the injury is clear. Okay. Alcohol or no alcohol, you're going to provide the same treatment, right? So here, the testing can wait. You get the point? It's a fantastic question. If he never regains consciousness, would it be tested for VSC? No, it won't be. If he never regains consciousness, what is the use of prosecuting him? Sir, of course, the courts can request. The courts can request, but that is way beyond the scope of your MRCS exam. Yeah.
Sir, if the patient is not unconscious in this particular, if the driver was not unconscious, would it be still necessary for us, even if he's not giving consent, to take his blood for alcohol concentration testing?
Yes.
If he doesn't,
that's what. That's what. If no. Yeah, he can refuse testing. That means he will have to be taken to court for refusing testing. That can be prosecuted separately. You still cannot take a sample if he says no. You can't allow take my samples. Okay. Now then it goes to the court and court will take the decision.
Okay, sir.
Okay.
Yes, sir.
Invasive intervention, colonoscopy or colorectal surgery. Which of the following information which is not should not be provided? Explanation of benefits and risks, including probability of success. Explanation of the purpose of intervention. Explanation of whether the treatment is experimental and success rates. Success rate of the doctor, of other options for management. E. Any more options? That's it. Only 2 people. C. What are the answers which need not be provided? So most of you are right. Majority is right. The answer is E actually. What is the information you should provide? You should provide the details of the diagnosis, options for treatment and management, including the option not to treat. What will happen if you don't treat? Option for further investigation. You can say that we are going to treatment right away, but these are the other investigations which can be done before treatment. What is the purpose of the treatment? The likely benefits and probabilities of success. You should definitely tell. Somebody answered C, that is wrong. Whether the treatment is experimental or not, the patient has a right. The name of the doctor will have responsibility. That is something very important. Always remind the patient that they have a right to second opinion. But you don't need to be informed of the individual's own complication rate. You should give the national rate of complication. Okay. So So, you don't need to, you can tell about the patient. Sorry, I'm sorry. You should tell the patient of the, what do you call, the own complication rate. But you don't need to give a comparison with the, that is something which they can do. Okay, so let's go to the next question. Same question, we should discuss child abuse. What is the answer? 9-month-old child. If you make a mistake in this answer, then I will have to, curse myself and say, Vinayak, you are not teaching well. What is the answer? Only Evangeline is answered. I want more answers, more answers, more answers. Good. The answer is obviously C. It's a long bone fracture in a person, in a child who is not yet ambulant. So this is suspicious. We have seen that already. Okay. You walk to the doctor's lounge, then you see your register friend who's on call. You start a conversation with him, and you find that he's too stressed to handle his work. He believes only to get relaxed after a puff of smoke. What is the best way to handle this situation? What would you do? For the people who don't understand what is cannabis is ganja, hashish, weed, pot, whatever you call it. Let's see, what is the answer? D. No. Okay. A. Is it so? D. Nobody for B. That's what you would do in many of our situations, won't we? The answer is actually B. Okay. It's 2 a.m. or 1 a.m. late in the night. GMC on-call advice is not going to be. If you ignore him and leave the place, then you are also likely to be prosecuted. If you tell him politely, there is no question of being polite here. He is putting patients at risk by smoking cannabis. His mental status is going to be impaired. So you cannot be polite at this point of time. You should ask him to call the consultant immediately and self-report. And if he does not do it, you should make sure that you do the self-report. If he doesn't do the self-report, you also don't report it, you can also be prosecuted. Tell him to discuss with the consultant in the morning. Absolutely not. The patient is at risk. Right. So the person in question should be encouraged to self-report herself or himself. If he does not do it, you should. It is the consultant responsibility out of us to deal with this incident. The registrar who is smoking cannabis should be removed from the clinical environment immediately. And the consultant, this never happens in a subpatient setting, but the consultant should facilitate by stepping down. The consultant, him or her, comes down and acts as the registrar for that night. And the other doctor does need to complete the call to protect patient safety. If no other doctor is available, the consultant has to come into that. The consultant takes full responsibility. And he has to report this instance to the trust and the GMC. Once the situation is made safe, it is likely that the registrar will face both trust and GMC disciplinary proceeding. He or she will be expelled from the medical company. Basically, GCS3, who is authorized to diagnose brainstem death? I think this is a question all of you who is preparing for MRCS Part A should be able to answer. Very easy. If this comes, this is basically what we call as a laddu. See, again, there is confusion. I think the most important point is there should be no conflict of interest. Surgeons are vultures. If we get a chance to operate, we will operate. And transplant team is not an exception to this, which means that both of the doctors should not be a part of the transplant. Answer E is right. And one of them must be consultant and both 5 years post. Okay. So they should be registered in the GMC post 5 years. But remember, they cannot be a member of the transplant team. So there is definitely a conflict. Okay. More questions. What of the following is correct regarding a consent process? You're going to remove a lipoma under local anesthesia. And you're going to perform the procedure as this thing. So what is the... So let's see people answering. Guys, So the following is correct regarding your discussion. You should state that you will be doing the operation supervision. Yes, makes sense. E makes a lot of sense. You should put a single identifier like patient's form. Is it a single identifier or multiple identifiers? You need not mark the site. Absolutely, you should mark the site. You do not have the see. The only thing you're giving is a local anesthetic, which means that even if the risk of reaction is less, but because it's a very serious reaction, you should mention it. Always have to mention non-operative management, as you saw prior. You definitely have. See, you should inform the patient that you will be doing the operation. You should be honest about your experience. Very, very important. Not like this GIF where you should say, trust me, I'm a doctor. One thing that. So all alternative options should be mentioned. And because very rare risk need not be mentioned usually, but risk of anaphylaxis with local anesthesia is a very important risk and that should be mentioned. Site always needs to be marked, even if it's a small procedure. 3 patient identifiers need to be put on the form. Patient's name, date of birth, and hospital or NHS. Very, very important. 3 patient identifiers, never forget it. Again, 72-year-old man, septic leg, planned for amputation, mental illness which is not being characterized. To the following is true. His opinion will not be considered. Again, we're going wrong way. His consent is necessary for surgery, septic illness, septic leg, mental illness. Owners of consent in psychiatric patient lies with the psychiatrist and surgeon. Okay. His consent is not essential, but his feelings and statement should be taken into his responsibility lies with the agendas. This is a confusing option. Or some of you have put C. You guys definitely need this course. I'm sure of this. None of the above. And that never is an option. That was just me trying to fill up the gaps. So, yeah, so there has been a small mistake over here. I think I had to change the option. So in this particular thing, the responsibility lies with the attenders. No, that is wrong. I had kind of removed it in the answer. So Kathorayan's consent is not essential, but his feelings and sentiments regarding the procedure should be taken into planning. The consent either lies with the LPA or the surgeon. Even in psychiatric patients, it must not be assumed that they are not entitled to give their opinions. So the answer is the owners of psychiatric consent lies with psychiatrists and surgeons. The psychiatrist need not be over here. If the patient is a known psychiatric patient, surgeon can take the consent also. So the correct answer is a combination of both C and D. I apologize for that small error over here. So basically, the patient's feelings and sentiments should be taken into consideration, but the responsibility lies with the LPA, and if the LPA is not there, the surgeon takes full. So the questions which I had put out for people who had registered for the testing discussion and paid for it, they had got the questions in advance. But I've added a few questions with medico-legal aspect. So basically, what does the National Institute of Clinical Excellence issue guidance on? For medical legal aspects, what book to refer for? Somebody is asking. No book to refer for. The only best resource is the question bank, because I have collated resources. Collated this content is from various sources which I have collated and made it very accessible to you. So the only resource you would need for this is doing the question bank. And I will be releasing the video lectures by the end of this month. I already shot that, and that is more than enough. Good medical practice, I think you guys definitely need this time. NICE is stand for National Institute of Health and Clinical Excellence. So it issues guidance on clinical practice, existing treatments, and guidance for social service and medicine. So the GMC basically, so I will, the answer is for intervention procedures. The GMC issues guidance on good medical practice. NICE issues guidance on intervention procedures, basically. Medical ethics is again by GMC. Patient safety guidelines are issued by National Patient Safety Agency. But in 2012, if you look at also the other question banks, it will be National Patient Safety Agency. In the 2012, the expertise was transferred to the NHS Commissioning Board Special Health Authorities. That is something which you should remember. Take a screenshot of this if you are not subscribing to any of the resources on Mortimer Green. If you subscribe to it, then you don't need to take a screenshot. It's all there, going to be there available. Risk management is an important component of clinical governance. Clinical governance is a concept which is very important. It will be covered in the videos and in the MCQ bank, but I'm not able to, for paucity of time, I'm not able to cover it over here. But yeah, I'll be talking about 7 pillars of clinical governance. Which of the following is not a 7 pillar of clinical governance? If anybody, you will not be getting a PDF of the session. You will be getting a recording of the session if you have registered for the course. Yeah, I think Unnati is on track to doing her MRCS in a fantastic manner. I think the answer is B. Cost control is not a part of it. You cannot answer this question unless you know about clinical governance. So Stephen Paulson is an anesthetist who exposed the high mortality rate for pediatrics cardiac surgery at the Bristol Royal Infirmary in 1995. He kind of created an impact because he was one of the pioneers in bringing about clinical governance, and that has kind of governed NHS to make sure that patient safety is paramount in whatever they do. So there are 7 pillars, and the reports are produced annually, but it is definitely a continuous process. The 7 pillars are education and training, clinical audit, clinical effectiveness, research and development, openness, and risk management. This is something you'll have to memorize so that you can exclude other options. There is no other way. Cost control is not a part of. Last question. This is a question regarding appraisal and revalidation process. I have detailed explanations in the question bank and in the videos, but for this question, I want you to tell what is not accurate regarding appraisal. And you will not be able to answer this unless you know what is appraisal. So basically, appraisal is an undertaking. It's an annual process in which there's a skilled individual who is trained as an appraiser, and it has 3 processes. So the first thing is inputs to appraisal. So for appraisal, there's a record of the doctor's scope, nature of work, and relevant supporting information. The confidential appraisal discussion is something which happens. The appraiser talks to a lot of people, including patients and colleagues. Inputs of the appraisal, including the doctor's own personal development plan and summary of the appraiser's discussion and appraiser statement. Appraisals are carried out between you and a colleague who has been trained as an appraiser. Anyone can become an appraiser. It need not be that it should be a consultant. It can be a GP. It can be an associate specialist doctor in the secondary care settings. Both colleague and patient feedback are used for appraisal and for revalidation. Both are equally important. An annual appraisal is a must for doctors working within the NHS, and this is a part of the 5-yearly process. So feedback can be something from the colleagues, or it can be from multi-source feedback or 360-degree feedback. These are all complex concepts which you don't need to, read in detail, but you need to know that 360-degree feedback is an essential component of revalidation. But 360-degree feedback is not a part of every appraisal. So revalidation occurs every 5 years, appraisal occurs every 1 year, and only if you revalidate yourself every 5 years, your GMC registration is maintained. Okay. So revalidation is done by a proper revalidation officer who is called as a responsible officer. So looking at the options, a revalidation reappraisal is done every 3 years. No, it is done every year. Feedback from colleagues has a lower weighting than feedback from patients. Wrong. It has equal weighting as your appraisal can be carried out by non-consultant doctor. Yes, this makes sense. Anybody can become an appraiser. It need not be a consultant. It can be on GP. Your appraisal should be carried by an NHS consultant who has been on specialist for 5 years. Again, same thing. 360-degree feedback is an essential part of your appraisal. No, it is an essential part of your revalidation, which occurs every 5 years. Thank you so much. We'll be making the videos available only for those who have registered, and I hope the session was useful. So we will be having 2 to 3 hour sessions. They're going to be very comprehensive. We'll be clearing as much doubts as possible. Today, when we look at breast, or you can say we spoke about medical legal aspects of surgery, we covered a lot of important concepts. And I think it will make a lot of sense for you guys to enroll yourself and make sure that you benefit from this. One thing which I can assure you is that last time, almost everybody who attended the test and discussion made it really well in this thing. This is a very important part of your training, and you might have doubts, and I think those doubts will also be cleared over here. Good day, guys. I hope you all achieve your dreams. I hope you all manage to clear MRCS Part A and Part B. And that we are able to play a small role in being a part of this journey for you guys.